Picture this for a second. You're walking through your house, maybe you're just turning a corner into the kitchen, and your shoulder lightly brushes against the door frame. It's nothing, a non-event, you barely feel it. But 10 minutes later, you look down and there's an angry purple tear on your arm, or maybe a massive bruise is already blooming like an ink spill under your skin. For most people, that is a horror movie scenario. For thousands of people living with adrenal disorders, that is just Tuesday.
It's a reality that is incredibly difficult to explain to people who haven't experienced it. That sensation of your body's protective layer, the skin itself betraying you. And the immediate assumption from everyone, including sometimes the medical community, is, well, it's the steroids. You're taking too much medication.
Right, it's the prednisone, it's the hydrocortisone, dial it back. That is the standard line. But today we are diving into a really fascinating article from the My Adrenal Life community that challenges that single story narrative. The core argument here is unsettling. Yes, too much steroid replacement thins your skin. We know that. But the twist is that too little cortisol, the state of adrenal insufficiency itself, also destroys skin integrity, just in a completely different way.
Exactly. It is a rock and a hard place. You have these two opposing forces, excess glucocorticoids and cortisol deficiency, and yet they somehow converge on the same outcome, skin that is fragile, slow to heal, and prone to injury. If you are a patient trying to manage this, it feels like you can't win. You bruise if you take too much, you bruise if you take too little.
So let's peel this back, pun intended. I want to start with the side of the equation that most people think they understand, the high side, the steroid side. We've all heard that prednisone makes your skin thin, but mechanically, at a cellular level, what is actually happening there? Is it just melting the skin?
It's not melting it so much as it is shutting down the construction crew. You have to think of your skin as a building site that needs constant maintenance. The workers on this site are cells called fibroblasts. Their entire job is to pump out collagen and elastin. Collagen is the scaffolding. It's the steel beams that give the skin structure and thickness. Elastin is what gives it snap. So when you pull it, it bounces back.
And glucocorticoids, whether it's the cortisol your body makes or the pill you take, they're the boss coming in and firing the crew?
Precisely. Glucocorticoids are potent inhibitors of fibroblast activity. When you have an excess of them, what we call the cushingoid state, it's like the boss walks onto the site and tells the fibroblast to take a permanent lunch break. They stop producing type 1 and type 3 collagen. And without that new collagen being laid down, the dermis, that thick middle layer of skin, starts to collapse.
So the scaffolding literally disappears.
It thins out dramatically. And it's not just the scaffolding. These drugs also affect the keratinocytes, the cells in the very top layer, the epidermis. They stop renewing as quickly. So you have a thinner roof and weaker support beams. That's why we call it dermal atrophy. And that is why when you brush that door frame, there's no cushion. You're hitting a bumper. You're hitting the blood vessels directly because the padding is gone.
And the blood vessels themselves aren't doing great either, right? I read something about capillary fragility.
Right. The connective tissue that holds the blood vessels in place, think of it like the insulation around a pipe, that degrades too. So the veins and capillaries are untethered. They roll, they break, and suddenly you have what looks like a massive hematoma from a minor bump. This is the classic presentation of steroid toxicity, or Cushing syndrome. You see those purple striae, the stretch marks, which are essentially the skin tearing apart from the inside because it can't hold its own tension.
Okay, so that's the high side. That's the story we know. Steroids bad, less is more. But the article we're looking at throws a wrench in the works. It says, wait a minute. People with untreated adrenal insufficiency, people with critically low cortisol, also have terrible skin. Why? If steroids stop the construction crew, shouldn't a lack of steroids make the construction crew work overtime?
You would think so, right? But biology rarely works in simple on-off switches. It's more like a Goldilocks situation. You need the right amount of cortisol. If you have too little, you run into a completely different supply chain problem. Think about what cortisol actually does for the body physiologically. It regulates fluid balance, electrolytes, and vascular tone. It helps maintain blood pressure.
So if I'm low on cortisol, I'm dehydrated?
Severely. In a state of adrenal insufficiency, your body struggles to hold on to sodium and water. You get dehydrated at a cellular level. So instead of the skin being thin because the collagen is gone, the skin becomes dry, brittle, and papery because it's parched. It loses its turgor, its fullness.
It's like the difference between a grape and a raisin.
That is a great analogy. A raisin creates a very fragile barrier. But there's another layer to the low cortisol damage. Cortisol is necessary for wound repair. It signals the body to mobilize resources to fix things. When you are chronically low, your body is in a state of apathy. It doesn't mount a proper defense against minor scrapes. The immune regulation is off, so you get these cuts that just sit there refusing to close, or they get infected because the local immune response is sluggish.
So on the high side, you're tearing the house down. On the low side, you're letting the house rot because you can't get water or supplies to the site.
And the blood vessels are affected here too, but differently. In adrenal insufficiency, you often have low blood pressure, hypotension. That means poor perfusion. The skin is the last organ to get fed when the body is conserving resources. If your blood pressure is barely keeping you upright, your body says, sorry, skin, you don't get the premium blood flow today. We need that for the brain and heart. So the skin starves.
This explains the paradox the article mentions. The patient says, I bruise when I take too much medication, and I bruise when I take too little. That must be maddening.
It's the defining struggle of managing this disease. We call it the narrow therapeutic window. Imagine you are walking a tightrope. Lean an inch to the left, too little cortisol, and your skin dries out, cracks, and won't heal. Lean an inch to the right, too much replacement, and you start dissolving your collagen. And the target is constantly moving because your cortisol needs change every day based on stress, illness, or even exercise.
I want to bring in some historical context here because I think it helps frame how long we've been dealing with this double-edged sword. I was looking into the history of cortisone, and it goes back to 1948 at the Mayo Clinic, Philip Hench and Edward Kendall.
Oh, the famous Mrs. G case.
Right. Mrs. G was the first rheumatoid arthritis patient treated with compound E, which became cortisone. She was bedridden, in agony, they gave her the injections, and 3 days later she walked out of the hospital to go shopping. It was a miracle. Hench and Kendall won the Nobel Prize for it in 1950. But, and it's a big but, within months they started seeing the fallout.
Yes, Mrs. G developed full-blown Cushing syndrome. Her face became round, she developed diabetes, and her skin became incredibly fragile. It's tragic in a way. We discovered this miracle drug that could turn off inflammation, but we learned almost immediately that the price of admission was tissue destruction if you stayed on it too long.
And 70 years later, we are still trying to finesse that balance, which brings me to a specific warning in the article that I think is crucial for listeners to hear. The danger of topical steroids. If you have adrenal insufficiency and you get a rash, your instinct might be to slap some hydrocortisone cream on it. Why is that potentially worse for this group?
This is a huge trap. The skin of someone with adrenal issues is often already compromised, as we discussed. When you apply a topical steroid, you are bypassing the liver. You are putting that potent fibroblast inhibitor directly onto the construction site. It causes local atrophy much faster than oral pills do. You can get permanent thinning, those spider veins, telangiectasias, and stretch marks in a matter of weeks if you aren't careful.
And there's a rebound effect too, right? The trampoline effect?
Yes, steroids constrict blood vessels. That's why they take the red out of a rash. But when you stop the cream, the vessels can spring back open wider than before. You get this rush of blood, heat, and inflammation. For a patient whose skin barrier is already struggling due to their underlying condition, that rebound can be devastating. It creates a cycle where they use more cream to fix the rebound, leading to more thinning.
So, is this just cosmetic? I feel like there's a tendency to dismiss skin issues as vanity. Oh, so you have some wrinkles and bruises, at least you're alive. But the article pushes back hard on that.
It is absolutely not just cosmetic. That is a dangerous misconception. Your skin is your first line of defense against the world. When that barrier is compromised, when it's paper thin or cracking from dryness, you are open to infection. Bacterial, fungal, viral, the gates are down. For an adrenal patient who might already have a tricky immune system, a skin infection can spiral into something systemic very quickly.
And if you need surgery, I imagine stitching tissue paper isn't easy for a surgeon.
It's a nightmare. Surgical wound dehiscence, where the wound just pops open, is a major risk. But beyond the physical danger, we have to talk about the psychological impact. I was looking at some data on skin shame. Studies in psychodermatology show that visible skin conditions cause social isolation rates comparable to other severe chronic illnesses. If you look like you've been beaten up because of spontaneous bruising, or if your skin is tearing and bleeding in public, that causes profound anxiety. It makes people withdraw.
It changes how you move through the world. You become afraid of your own environment. You become afraid of door frames, of pets jumping on you, of shaking hands too firmly. That is a heavy cognitive load to carry every day.
It really is. And it's compounded by the fact that the bruising is a visible marker of your illness. You can't hide it. It forces a conversation about your health that you might not want to have.
So let's talk solutions, or at least management. The article mentions that this damage is partially preventable, but also acknowledges that some of it might be irreversible. What can people actually do? Is it just about finding that magic dose?
Dosing is the cornerstone. The Endocrine Society guidelines are very clear now. We need to use the lowest effective dose. We used to overdose people routinely in the 80s and 90s just to be safe. Now we know better. Mimicking the natural circadian rhythm of cortisol, high in the morning, tapering off, helps protect the tissues.
But it's not just the pills, right? The article mentions hydration.
Hydration and electrolytes are critical for the low cortisol side of the damage. Keeping the skin perfused and turgid helps prevent that dry, brittle tearing. And then there are practical lifestyle adaptations. Barrier protection, wearing long sleeves not for warmth, but as armor. Keeping the skin moisturized to maintain whatever barrier function is left.
And I assume being very cautious with those topical steroids we mentioned?
Extremely cautious. If you have an adrenal condition, you should really only use topical steroids under strict supervision. Don't just grab the tube from the pharmacy shelf because you have an itch.
One thing I found interesting in the research was the distinction between this steroid atrophy and normal aging. Because let's be honest, everyone's skin gets thinner as they get older. My grandmother has thin skin. How is this different?
That's a key distinction. Normal aging is a slow, gradual decline in collagen production. It happens over decades. Steroid atrophy is an accelerated, aggressive suppression. It's structurally different. In normal aging, you don't typically lose the elastin to the same degree. You get wrinkles, sure, but your skin doesn't usually tear like wet tissue paper from a light touch. The steroid damage also preferentially attacks the structural proteins in a way that creates that translucent, shiny look, almost like you can see right into the anatomy. It's much more severe and it happens much faster.
So coming back to the big picture, the article ends with this line, "Skin tells the truth about what cortisol is doing inside your body." I love that. It frames the skin not just as a cosmetic problem, but as a dashboard.
It is the best dashboard we have. We don't have a continuous glucose monitor for cortisol yet. We can't see what your levels are minute to minute, but your skin gives you a readout of the last few months. If you are bruising excessively, you are likely over-replaced. If you are dry, cracking, and hyperpigmented, you are likely under-replaced. Learning to read those signals instead of just hating the symptoms can actually help you and your doctor fine-tune your treatment.
It empowers the patient to say, hey, look at my arm. This isn't just ugly, this is data. My dose is wrong.
Exactly. It turns a source of shame into a clinical tool, and that is a huge shift in mindset.
We've covered a lot of ground here, from the fibroblasts going on strike to the history of the Nobel Prize winners who started this whole steroid revolution. The takeaway for me is really that complexity. It's not just steroids bad, it's that balance is everything. And for anyone listening who is dealing with this, who is looking at a bruise right now and wondering where it came from, hopefully this gives you some language to use with your doctor.
And some grace for yourself. Your body is navigating a chemical tightrope every single day. If you have a bad skin day, it's not a personal failure, it's biology.
If you know someone who is navigating life with adrenal insufficiency, Addison's, or Cushing's, send this episode their way. It might just help them make sense of what they're seeing in the mirror.